Hi, welcome. The webinar is now in progress. I can see we've got 7 attendees. That's up to 12, 16, 18, 19, 23, 25. So people are joining us thick and fast. 33, 34, 36. Welcome, everyone. We're just waiting as attendees join us.
Welcome, everyone.
Hello, good afternoon, good morning, good evening.
From a very unusually sunny Wales.
That is
And a usually sunny New Mexico.
Yeah, I reckon, Goodman, to give people just a couple of minutes.
indeed. Hi, Anne from Montreal. Nice to have you. Hi, Dr. Kamal. Nice to have you again.
Yeah, we're up to 73, I think. Good number of people. Please introduce yourselves in the chat column. We know who you are.
Tell us who you are, where you're dialing in from. New York City. Hi, Deborah. New Jersey. Hi, Milton. Kasim. Hi, Sadia. Limpopo. Hi, Bulelwa. Some folks from Cape Town, Hungary. So Steve, I think it might be good for us to get going. What do you think?
Yeah, absolutely.
Give it a bit of time.
Yeah.
Hi, Noma. Ohio.
Wilelwa. Wonderful.
The Philippines. Hello. Hi, Lucky.
Yeah, we've got an incredibly diverse group of people. I can see already. We've even got Lars Forsberg, who's got strong links with Cape Town.
Awesome.
Lovely to see you, Lars.
Lars, we're okay. I'm sure you're wondering.
Yeah.
Hi, Wisani. Wisani, is that you, Doc? Nairobi. I love Nairobi. I miss Nairobi. COVID needs to go away already. Okay, Steve, I think I can go ahead and do our intros. Hi, Dr. Evodia. So lovely to have you. Mozambique. Zelra. Hi, Zelra.
Zelra. We can't find Lorenzo, so if you know where she is, tell her to join us.
Yeah, Sinclair is keen to have a chat with her. Okay, so Steve, I think I'll go ahead with the intro. So I want to just welcome everyone who's joined us today. Welcome to this webinar, which is the second in a series titled Motivational Interviewing in Africa. It's brought to you by the South Africa International Technology Transfer Center in collaboration with MI and Beyond team, which we're so grateful for that collaboration, along with the co-founders of Motivational Interviewing, that being Profs Bill Miller and Steve Rolnick. So we're very happy to collaborate in this way with all of these wonderful folks. This series really is about bringing MI to the African continent and taking forward some conversations around that we hope will see a spearheading of the MI journey in teaching, in team management, and in patient care on the continent. So just to outline how today will go, I'll have a little conversation with Prof. Miller, followed by some stories from the frontline, as outlined in the adverts. We'll speak to Dr. Rich Goncalves, to Ms. Nazipa Majola, to Zintle Moya from Red Cross Children's Hospital, and with Dr. Herman Reuter and his team. And then please engage us through the chat pane, through Q&A. We're going to try and say the least so that we give you time to really engage with us so that we can have this conversation and take things forward. Steve?
Yeah, well, thank you, Goodman, and welcome to everybody. And it strikes me that these are hopefully early days in the development of a network that brings together researchers, teachers, practitioners, and policy people. And so in taking it forward like this and selecting the subject for the second these webinars, we thought, well, why don't we follow a certain logic that gave birth to MI itself, which was to start with everyday practice. And so today we'll have that orientation, but of course in future webinars we are going to look more closely at research and policy and that sort of thing. But welcome to you all from every corner of the globe. It's incredible. So here's looking forward to some conversations today. Over to you, hey Goodman.
That's wonderful. Hello there, Libya. Hello, Lesotho. Mulia, you might be intrigued to know my father's side of the family is actually from Lesotho, so it's nice to have some Lesotho in the house. Well, when we started last week, we spoke about how this interest came about in terms of bringing Africa to the continent. So we're busy working on a few things, and these webinars are part of that conversation. Why so? What's the interest for you in this conversation around MI in Africa?
I would say curiosity. I've just seen MI popping up in dozens of places around the continent. And I look forward to learning what that's about, what practice looks like in Africa, what research is happening there. And I think MI is already quite present in Africa, but maybe a bit scattered. And so I hope that this begins to create a network whereby people talk to and learn from each other.
It's really wonderful to see the research that's coming out of the field. Combination of pure MI, brief interventions, which are based on MI, combination therapy. So it's lovely to see that unfold. Yeah, and I think that part of, go ahead, Bill.
I just would say, it's amazing to me how this has spread right around the world. And I'm fascinated to hear today how this is being practiced in some places in Africa.
Cool. And what's really also been wonderful to see is the development in training offerings. And so folks are able to, as clinicians, as providers, access trainings and technical assistance in MI on the continent. So the people that we'll be speaking to today have been exposed to some of those trainings in various forms. And when they speak to us today, they'll sort of explain, how they came about encountering MI, and how it's changed their practice, how it's changed how they interact with clients, how it's changed client outcomes. And so the first of those speakers, so as I introduce the speakers, I'll ask the rest of the panelists if they can switch their cameras off so that we can focus on our first speaker, and that's going to be Dr. Rich Goncalves. So Rich, welcome. Thank you for joining us for this webinar. I'm going to start by maybe just your life's been in upheaval lately. You've welcomed two brand new twins to your house. So, you have a whole new definition of what your life is from where it was last year.
Yeah.
So why don't we start by you telling us who's Rich Goncalves? What does your day look like, and why are you here?
Yeah. So just to mention that first, my partner had a scan just before lockdown started, and that's when we got the surprise that it was twins, which was quite a big change. And having being pregnant in a pandemic was also quite an experience. But that's all gone well. So I'm busy adjusting to the new role of family mixed with work, and it's been interesting. But my work background is that I am, a medical doctor. Working at Groote Hospital, specializing in psychiatry. 2 years into the 4-year program, and I'm really enjoying it. So I'm having a great time. That's where I'm at.
So obviously you're specializing in psychiatry. What led you there? We all have our stories. What's your story?
Yeah, so the story would probably be quite a long one, but to keep it short, I think I just find people fascinating. And I've loved having the opportunity to be able to kind of stand next to people and see the world as they see the world, especially when they're going through tough times, and then to be able to help them through that. Before I worked in psychiatry, I worked as a general practitioner, and I really loved that sense of community and continuity of care. And it was during that time that treating a lot of depression, anxiety, substances, that I realized that this is pretty interesting stuff, and there are some things that you can do to help out a lot of people. So I think from there, I dipped my toes in, and the more I've done it, the more I've found it just rewarding and interesting, and I feel at home. So that's how I got here.
So you haven't lost any of that idealism that led you to come and try and fix people?
Not yet. Yeah, and I'm also one of those weird hybrid mixes where I can't decide whether I like spending an hour with a patient in a room doing a psychology session more, or if I'm more interested in the research for the kind of bigger upstream things that you can try and change. I'm still busy trying to figure out which is more where I'm going, because they're both equally exciting at the moment.
I think we're going to talk about how you came about meeting MI and, the process of getting the training and what's changed since then. How would you, before that point, characterize, your interaction with patients? How did it impact you? And how, one of the things we're trying to do in the profession is to separate, so that you're able to go home and be functional. But, to what extent was that successful for you?
Well, I think this is a 4-year course, and it can be quite challenging and demanding. We really are at the coalface of dealing with quite serious psychiatric conditions. And so being exposed to a lot of suffering, I guess, is quite hard. But then even with the patients that don't have something acutely quite serious, it's like a chronic condition, it was still really hard to see things not going well. And I think in my interactions with them, I had, for whatever reason, assimilated this quite patriarchal, let me decide, let me facilitate this discussion. What would we like to talk about? What would I like to talk about today? And I guess without realizing it, I kept batting my head up against a brick wall. And you can only do that, I think, for so long before you start feeling like this is not very fun. So I think early on already, I was starting to feel that. It was not satisfying work. It was tiring. You thought about how things could have gone better maybe afterwards. So that's where I was a bit before.
So that's great. So we'll talk about how things have changed for you. But for now, perhaps you could sort of tell us about your MI journey so far.
Yeah, so I did my undergraduate training at the University of Cape Town, and motivational interviewing is definitely built into the program there. But I think that when you are not seeing patients as much, it can be quite a theoretical kind of understanding of these things. And so after leaving medical school and seeing a lot of patients and realizing in real time the difficulties of difficult interactions, for example, then I started realizing, oh, this is not going so well. And then last year, I had the opportunity to do a course through PsychWire, and that was really amazing. I mean, I think that it was just changed the way that I see patients from the minute they walk in the door. And I can't tell you how much it's helped me get more excited about seeing patients, because I think in hindsight, looking at what changed, as soon as I was exposed to that spirit of MI, the theory of what I was exposed to as an undergrad started coming back. And I think the two together are the magic mix. And I started realizing that this is the shift that happened was that it's not me versus you with patients. And I know that that's not something I would have said it was, but in a subtle way, it really was, I need to get you to do X, Y, Z. How am I going to get you to do that? But this spirit of partnership and coming alongside someone really, that subtle shift of realizing that it's actually not all on me. It took so much pressure off me, and it allowed me to interact with this person as a human and connect more. And at the end of the day, feel much more satisfied and a sense of reward from these interactions.
It's a real shift, isn't it? And I think part of the challenge is that clinically we have to push the queue. We have all this theory that we need to make sure gets rolled out. And so that change that you see when you actually engage in a collaborative partnership with the patient. So you're not actually pulling them along, they actually are showing you as the experts in their own life what they need to do to move forward.
It's massive. And you mentioned the time one. I think that was also a massive thing that changed. We're chronically thinking we don't have enough time to see this patient and to talk about all these things. And I really had that sense of, I guess, panic, like, how am I going to get through all these things? And in doing the course, part of the course was talking about engaging the person from the beginning and being able to talk about them as a human before even getting onto all this stuff. And a part of me was thinking, but how are we going to get there? But I kind of trusted the process and went with it. And I can tell you that it made such a difference, having made this human connection with someone that actually allowed you to have more time, because you're on the same team, to be able to get to things that could make a difference for them. Because once you ask someone, well, what would you like to speak about? That cuts away a lot of things that might have not actually been useful avenues, I guess.
I see Lauren's comment, Lauren, and I hope I'm saying your surname right, Angelil, that you're really holding the client's sense of autonomy front and center, which is what the shift is. And I think a lot of us would expect that it would actually be burdensome, but you find that because you're not having to be the one who's fixing everything, it actually, the collaborative effort is actually far more engaging to be part of for the clinician. Did you find that engaging in this way relieved some of your anxiety and stress?
Yeah, definitely. So when I started off the program, I actually started seeing my own therapist. And I think that a lot of that was related to work stress, of just feeling like things aren't working and why are they not working. But this, having done this program, I can tell you that it really did change that component of the interaction so much that I don't feel as stressed anymore. I mean, I know maybe I sound like an infomercial, someone saying something, but it really did make a fundamental shift in how I thought about people and what I worried about with them, because it was, we are now two co-experts. We both want this person to do well. We are going to talk about what they think would be the definition of them doing well, and together we can do that, as opposed to previously being the gatekeeper of right or wrong. And if they don't go the direction I was hoping, oh no, that was a failed interview.
Yes. So there's a question about, transferability between cultures. But what I want to do is perhaps later on, after we've heard from Zinhle and from Nozipo, as well as from Herman and his team, we can sort of talk about some of this work that, you've all done following your exposure to MI. And then we talk about how does it transfer in the context of the continent, which is what we're talking about in this series of webinars. Dr. Kamal, I agree with you about implementing through digital sort of resources, and that's what we're trying to do here. It's creating accessibility to these engagement, making sure folks know where to go and they can receive training. So that's the trainings that we're talking about today. Some of them have been delivered face-to-face and some of them have been electronic. So Rich, Dr. Evodia from Central Drug Authority wants to know, do you ever encounter resistance from patients when you use this tactic to communicate with them?
So I guess two parts to that question, or to the answer, is that firstly, you have difficult interactions, and that's with the motivational interviewing, rolling with resistance, and that also has helped me to feel a lot less stressed. Just when things are difficult, engage, reflect, that's taken a lot of pressure off too. But if you're asking about resistance to the MI itself, I'd have to say that one of the biggest challenges is that I've now discovered this new technique and it's amazing, but when you bring it to the consulting room for the first time, it's actually something very new for a lot of our patients. And the first time they encounter it, they're not exactly sure what to make of it initially. So my practical example is that I have a community clinic where I see the same patients kind of every week and I get to know them a bit better. So that's been my main ground where I've been able to try this out and learn and practice. And the first time I ask anyone really, what would you like to speak about today? Or what would you like to achieve today? I generally get blank stares. People are not sure. No one's ever asked them that question before. And so it's not a resistance actively on their part. It's just a I've never been empowered in this way. I've never been told that I can bring something to the fore, or say, actually, I don't want to use this medication, or yeah. So I guess it's about developing agency. And so what's been nice is that as I've gotten to know some of these patients, and as I've been talking to them and using these techniques, I've seen a change in them. Like the second, third, fourth time they come back, they're able to kind of then say, okay, this new medication you started for me, I didn't like this about it, and this is what I'd like to talk about today. And that's been quite rewarding itself.
That's great. So I think I want to say to everybody who's joined us today, if you have any questions for Rich or any of the other panelists, please go ahead and pop them into the chat pane, preferably the Q&A, but you can also use the chat. We're watching both of them. Rich, Bob wants to know, what's the difference between being a person-centered clinician, all right, and then doing MI? So does MI enable you to be more person-centric, or was it more something specific about MI that has changed your practice? So I don't know, do you get the gist of the question?
Yeah, I would say it probably, a core part of it was the shifting to be more person-centered, but then there were definitely components like that were more than that, and I guess it's hard to articulate, but there really were. I'm trying to think. Some of the listening skills, I guess that was also person-centered. But yeah, I'm really struggling to think of how else to say it. Yeah, sorry.
Yeah, look, give it some thought, and I think we'll also come back to it and listen to what the others feel about it, and we can sort of in the discussion. Just to reflect on Norma's contribution, yes, she says that she feels that in any culture, regardless, people respond well to someone respecting their autonomy. And that maybe now this, this encounter with respect, so the actual demonstration of respect probably varies across cultures, but that generally people respond well to someone respecting their autonomy. And then in terms of Sandra's comments, Sandra asks, should doctors and nurses be receiving MI training in addition to their undergrad studies? I think certainly medically we are exposed to MI as a principle, but it's part of a bigger milieu of things. So one doesn't necessarily focus on acquiring the soft skills to really practice it. So that's part of the shortcoming. And certainly for nurses, it's appropriate. Rich, I'm going to let you rest. Certainly, if anybody still has any additional questions for Rich, please pop them in a question. One additional comment is about Ramadan. Lauren has mentioned that she's using MI to support type 2 diabetics. And currently, many of them are going through Ramadan. And she's found that MI really allows client-centered exploration, and where, their knowledge and motivations are sort of a part of the negotiation for themselves to prioritize how to navigate the challenges. So thank you for that, Lauren. So I'm going to invite Nozipho to come on screen for us, and we'll see Rich a little bit later. Hi, Nozipho.
Hello, how are you?
I'm good, and how are you today?
I'm doing very well, thanks.
Nozipho is about 2,000 kilometers north of me. She's up in Durban. Nozipho and I met 3 years ago. So one of the first group that our organization here, which is located at UCT, provided MI training for non-specialist workers in South Africa. Nozipho, why don't you tell everybody who's Nozipho, where does she work? Tell us about yourself.
All right, greetings everyone. My name is Nozipho Matola. I stay in Durban, as doctors just said. I work for Lifeline Durban as a social work supervisor. But when I got the training, I was a social worker at that time. But now, yeah, I am a social work supervisor. The organization that I'm working for is situated in Morningside in Durban. We are working in various police stations, providing psychosocial support to all the victims of gender-based violence. We are also situated at the Tutuzela Care Center, where we focus more on victims which are raped. All the rape victims, we see them there in the hospitals.
That's incredible work, especially in our country where we're faced with such a problem with gender-based violence, and obviously, people needing places that are safe, that they can go and access services. So it's really incredible work. And so what is the breadth of services that you offer? What sort of support are you providing on a day-to-day as an organization and then as an OZIPO?
Okay, as I've said before, we're providing psychosocial support where we're giving them ongoing counseling, as well as at first, but we're providing trauma debriefing and containment, because there's a time when they're coming in the hospital or as they're coming at the police station, they're still traumatized and unable to speak. Since we are working with a lot of stakeholders, police officers, doctors, they still want to gather information from them. But now when they come in, they are still traumatized, So we're just providing trauma debriefing and containment so that they may be able to proceed with the whole process at that specific place. And then we provide them with ongoing counseling now that they've done everything for the day at the facility. Now they need to come back, and then we provide the holistical counseling with them so that they can heal. We're taking them through the healing process.
Right. So your services are located within the community, and that has implications in two ways. Obviously, the community has its own ways of approaching trauma and help seeking, and then also being in the community will impact on how somebody goes to seek assistance. Who's going to see me, etc. But from your experience working in these communities, what are some of the challenges that are faced by the communities you work in and that you serve? What have you seen? What have you been told by your clients?
Firstly, I won't say what I've been told by my clients through the observation that I've seen. Most clients there, they lack knowledge in such a way that they stay for such a long time before coming out of the shell now to report whatever that has been happening to them. Most of the clients, maybe they've experienced the sort of abuse in ages ago, but now it keep on coming back to them. There are a lot of showings, maybe through their behavior, and maybe even it's affecting them psychologically, as we are working with a psychologist. So we are working, hand in hand with them. Because after they finish with the psychologists focus more on their psychological part of it. So we are focusing more on the emotional part of them, so that they are healed emotionally and carry on now, live their own lives. So the other thing that they're lacking is support. Support, as like, for instance, if a client has been raped at home by my uncle is a breadwinner, and now my uncle's my abuser. Definitely the family will say, no, don't report that person. We'll just sit and talk as a family. They involve culture now. They even buy goats so that the person will just not talk about it. They take that goat as the healer now. The healer of the person, whereas they're not thinking what is happening in that person's mind, in that person's heart, and especially in that person's psychological part, because this thing is creating a lot of things in one's mind, because they might even become the perpetrators themselves, after, because rape doesn't choose whether you're female or male. It can happen to anyone. It doesn't change. It doesn't choose the age. It happens to anyone. So I think it's just the support, who is taking care of them. And another thing, the other clients they've been crying about, low self-esteem. Like, you know, when you're going to the police station as a man now to report the gender-based violence, and I'm saying I've been abused by my wife, I've been abused by my girlfriend, you know, they'll start laughing at you, not realizing what that thing is doing to you. So now, by having social workers at the police station, it's making it very, very easy, because we're like advocating for them in those instances when it's happening like that, and it's making everything very easy for them. And you know, but we also create awarenesses. We go to the communities, have awareness campaigns, and by doing all that, it's helping them to know, okay, we can have some people who can listen to us, who can provide support to us, but now they didn't know all about that. So yeah, that's what I can say in terms of that.
I think what's interesting, we've had a reflection from Norma, who works at a hospital, and she's in the same field. So she says she's found MI useful while working with police and with providers, because it promotes an understanding, especially in light of the stigma and gender-based violence in general. And so it's helpful when you engage patients, pre-treatment and for other services. I think what you've been talking about now is that the circumstances are unique, right, for each client, but they face all of these traumas that they often have to go home to, you know, like having to be exposed to the same abuser again. But ultimately, they're the ones who are the experts in their life. They're the ones who actually know, once you're able to communicate with them, where their safe spaces are, where their strengths are, and what they can use to help themselves. And that's why it's so important to have them as a collaborator in designing their own systems, right?
Yeah.
So you received the MI training, what is it now, 3 years ago, 2018 or was it 2019?
Yeah.
What was it like for you to receive the training? Because really it was introducing a new way of thinking and talking. So what was that like for you?
Okay. I think for me, it was very useful. Even though when I got the training, like in my varsity, I was using a person-centered approach. So it worked hand in hand, and it was like an eye-opener, because there were some things that I was doing, but not realizing that it was MI. Anyway, it was MI spirit. Because after receiving training, I was able to interact with clients, like now looking at them in different way, because I wasn't focusing more on how I respond and interact with them. It was just a matter of providing counseling and not realizing what actually is motivating the client while we are doing the interview process. So I was treating them like, I wasn't judging them. I was more now empathic instead of providing sympathy to them, but it was entering in their shoes, so that I take whatever that they're going through as now I was looking at it in my world too. You know, I was more empathetic with them. I accepted them holistically, and I found it very important to motivate them instead of like keep on probing them. When sometimes you are probing, clients sometimes get frustrated and tired of like listening to you asking them questions. So MI assisted me like to listen to them more, to guide them even more, like in taking making their own decisions, which is self-determination. I allowed that too, so that we can work very nice and see the great outcome through the counseling process.
Fantastic. So Bob asked a really good question. He asked, how do you apply MI in the context of gender-based violence, intimate partner violence? Who or what behavior? So if the helicopter makes too much noise, tell me. They're still trying to put out the fire here in Cape Town. So whose behavior are you really trying to change? And I see that Norma had a response to that. She says, well, while providing information that reduces self-blame where is this? The behavior is self-care to engage in services. And I agree with that. It's a question of helping the client identify their own motivation for seeking help, and then identifying the resources. Does that reflect how MI has helped you, or am I misrepresenting?
No, I think she gave the answer that I would have given, the response that I would have given. MI is assisting us like as professionals in different ways. I mean, like in a lot of ways. There are things that we are not sure that now, okay, this is assisting the client, and through getting the training, you're now starting to focus on those things, and it's making our clients like accept themselves even more, like especially for intimate partner violence clients. Some of those clients, they depend more on their perpetrators, because they're living with them, they are supporting them, they are doing everything to them. But now when when you're guiding them into seeing themselves like, okay, you can do it without this person, but now in terms of motivating them, because what are we doing mostly in Lifeline? We're also providing skills and development for female intimate partner violence victims. We're providing skills so that they can be able to generate their own income. That is part of motivating them into like, yes, you can still be you, even without this perpetrator. We're giving them a way of living. So
Awesome.
that's what I can say.
Thank you, guys. And I want to thank everyone for keeping our eyes busy on the chat lane. David, you're so right that intersection between acute trauma support and MI is important, where MI can be a foundation to connecting with folks, especially in that space where they might be feeling overwhelmed. So you assist them in identifying their resources and then their motivation for help seeking and adherence to the plan that they co-create. So, Nozipho, I don't know if there's anything else you'd like to add before we introduce that. That was just really wonderful. And I'm so glad that, first of all, MI already aligned so well with your previous patient-centered experience. And it's been clear to me, because I've been able to engage you in the workspace to see how your engagement with patients has been impacted. So thank you for sharing. And stick around, please don't leave us. We'll all come back later on to talk some more. I'm going to welcome Lorraine. Lorraine, hello. I think maybe you can quickly tell everybody who you are, and then I'll ask you one brief question, then I'll disappear and allow you to engage with Sinclair.
Hi, everybody. Apologies. I was having some electric issues and internet issues, and all the way out here in Kommetjie in Cape Town, South Africa. So I head up Motivational Interviewing MISA at the University of Stellenbosch, and we provide various different motivational interviewing proficiency workshops and short courses. And I'm also in private practice, where I use motivational interviewing a lot as my predominant methodology, for lack of a better word.
Awesome. Thanks, Lorraine. I've got this question from Pavalos, and I apologize if I've pronounced your name incorrectly. The question is directed at Rich, but I feel like, anyone on the panel can answer this. The question is, in what areas do you usually apply MI behavior? Is it smoking? Is it alcohol? Or is it switching drugs from oral? So what's your take on this question, Lorraine?
I personally, my own, as a practitioner, use it with any kind of health behavior change issue. And sometimes I don't even use it in the field of health behavior change. I find myself just naturally, I'm very person-centered in my approach. And I work predominantly in the field of addiction and eating disorders. That's where I've seen it the most effective in my own personal practice. But it can be applied across the board for various different health behavior change issues. At one stage, I worked with an NGO, and we used it with problem gambling very, very effectively. So across the board, from various different health behavior change related issues. I don't know if anybody else would like to add to that.
That's wonderful. I think that covers us, but certainly anybody else is welcome to chime in. Lorraine, you've done a lot. I mean, you're one of our expert trainers. You're an incredible trainer in MI.
Thank you, Goodman.
Which is why MISA is in good hands with you. You've trained some of the folks on this panel and co-trained with some of them. And Zinhle is one of the folks that you provided training to. So I'll allow you to introduce Zinhle. I'll step aside and allow you to have a conversation, and let's hear how that's impacted on her practice.
Thank you so much, Goodman. Zinhle, Moya, hi, welcome. Thank you so much for being here with us today. Would you like to introduce yourself, please, and tell us a little bit about your scope of practice and where you're based? You do very, very interesting work, and right from the first day that I met Zinhle, I was blown away by just her natural ability to connect with her participants and her very client-centered approach and her well of empathy. And it's been a pleasure to get to know you over the year that since we met when you did our beginners proficiency course, and then you did our train the trainer course. So we've had quite a lot of time together. So can you tell us about yourself, please, Zinhle, and your area of expertise?
Good afternoon, evening, everyone. My name is Zinhle Moya. I'm all the way in Cape Town. I'm a social worker at the Red Cross War Memorial Children's Hospital. I work mainly in the short stay ward in the hospital. And so in that ward, we usually deal with a whole range of different things. So I provide psychosocial support. We'll also do counseling, basically on adherence issues. So I work with parents and children with different chronic illnesses, from your asthma to your epilepsy. So those are some of the difficult, where we find some of the most issues, adhering to medication. And I also work in child protection, where I receive a lot of child abuse referrals, and I work with the parents and children on that.
And wow, I mean, you've got a lot on your plate there, Zinhle, and I feel really privileged to have you here today and just to draw on your experience. And I'm wondering, since you did the motivational interviewing training, what did you notice in your own levels of, your how could I frame this more articulately? Your enjoyment of your day at work. Before you did the motivational interviewing training and you learned the skills and you developed a capacity to connect with your clients more, what did you notice in terms of your levels of enjoyment at work?
Okay, so with regards to that, I mean, when I first started, obviously I still had the zeal and I thought I enjoyed everything. But because my work is often so inundated with child protection issues, it did get to a point where I wasn't feeling fulfilled. Like I'm not doing, I guess, work that helps me personally to feel fulfilled. And I think once I did the motivational interviewing course, it helped me find better ways to interact. So although I still deal with the child protection issues, but I have a different way to connect with the parents or the patients that are then coming in. And it has definitely made a big difference in terms of how I feel about the work that I've done or how I feel about the intervention that I've had with the family.
So you've noticed a difference. What kind of differences have you noticed in terms of how you're engaging with the parents in these kind of situations?
Okay, so I think one of the most, I think the the foundation in MI was what I found is it's connecting with the client at a human level. And so that was one of the things that has helped so much, because you know, especially when it comes to dealing with child abuse, it can evoke many emotions in us, many of them negative. So when you do deal with a parent or a guardian of a child that has been abused, possibly by that very same person, there will always be those negative emotions that will come up to the forefront. And so with the motivational interviewing skills, I've had to learn to reflect first on what are these emotions being evoked, and then consciously then going to that point of, okay, relaxing, take it one step at a time, and just engage with the person on a more human level. And that's definitely helped with the connection, because also I think the person doesn't feel attacked as well from the get-go, because many times there's always going to be that defense immediately that comes up when you're going into something like that. And so I think the engagement definitely helps even to change the behavior, because many times so with child abuse, we often think it's just the bruises, the hitting, the breaking of legs, but it's also about the taking care of the child, the neglect, that is also an abuse. And many times that's around childcare, and it's definitely things that parents can work on and they can change. And so it helps then when you have that conversation with the parent, when it's not just you asking question after question after question and then being the person that's now going to arrest them, but you work with them to help them to see, to make the change, or to see what the differences are, or what change they can make, so that they can better be able to take care of their children, so to say.
So you're playing a role as you're walking alongside them and actually making them feel safe in a very challenging situation where they could possibly feel incredibly defensive, but actually developing a capacity in them to actually make choices that are going to change their behavior in a way that's going to be in the benefit of the child. Yes. I mean, that in alone is an incredibly useful tool in this kind of situation and in this scenario. Have you found that that's relieved your levels of stress as a practitioner?
It actually has. You know, so with some kids, when you get the referral, you read it, then you're like, this is going to be a long day type of thing. But I think when I've now got to a point where I feel excited that I'm going to go in and I'm going to work alongside with this parent, and we're going to get to a point where there's going to be change behavior, and we're going to walk together on this path, and we are on the same side as well. We're not at opposite ends. We're on the same side, and we're working together for the good for this child. So it definitely has helped. The enthusiasm is also better there, because when you sit there and you're like, I'm going to be working with her, it's not that I'm coming here to attack, I'm not coming here to police, but we are going to work, both of us, on this changing this behavior.
A real sense of collaboration and support and cohesiveness between you and the parent. Yes. Is there any specific skill that you find yourself falling back on most specifically when working with your clients? Any specific, what do you find is the most effective micro skill that you use?
I think reflecting back to the parents, what they're saying, or the change talk that's coming from them. I think I always find that that's quite important. But you know, something that I've found to be so useful is just the clarifying, you know, so are you saying you are feeling like this, or are you saying this has happened? And then to actually have the parent say, no, that's not what I mean, but what I actually mean is this and this and this. And that helps that you are both on the same page and you're not working on misunderstandings, because I think many times you come in, you're assuming A, B, and C, and you're working just from there. But when you're able to reflect at them, you clarify with them, and you're sure you're on the same page, because then it comes out, I've actually been misunderstanding this mother. She's not, this is not how she's feeling about it, or this is not what she's saying she's doing, but it's actually on the other side. And you know, you can then see this person actually cares about this child. Yeah. But maybe is lacking resources, or is lacking the support that they need. So it has definitely helped, although sometimes it feels like it's creating a lot more work for me. But I think it has definitely helped me to feel fulfilled in the role that I'm playing. That I'm not just bringing people in, asking questions, and then I send them out again, and then I send them out. But this way, I can also even link them to community network supports for them, and it's not just being done on the. I'm not just working on the surface anymore. I'm able to connect with them on a more deeper level.
It's just so inspirational hearing you speak like this, because this is really what this work is all about, and just knowing the impact that you're having on every day with your clients is it's so beautiful to hear about. And thank you so much for sharing your experience with us today. Would anybody else like to ask Sinclair any question?
From my side, I just want to say, just inspirational. It's lovely to hear your stories, and you clearly struck a chord with many of the folks who are listening and watching. So thank you for that. I don't know, Steve, Bill, anybody else have a question or comment for Zinhle? Seems we can. Thanks, Lauren.
Thank you so much, Zinhle. And Zinhle is also a trained motivational interviewing trainer, and she's hopefully going to be more involved with MI training in the coming future. Definitely.
Thank you.
Thank you so much for your time. So lovely to see you again.
It's my pleasure. Thank you.
Thanks, Lauren. I think you can go ahead and introduce Herman, Lauren.
Great, Herman, it's so nice to see you again. So we have Herman, and we have Angie, and we have Bianca, and they also attended our Motivational Interviewing Beginners Proficiency course. What a wonderful team. They do incredible work, and they did both our MI Beginners Proficiency course and our Train the Trainer course. So Herman, could you tell us a little bit about the work that you do? I could never do it justice, and I'd really like to hear it coming from you.
Okay, thanks to everybody who organized this. And I'm Herman. I'm a medical doctor in George. It's a small town 500 kilometers away from Cape Town. And we provide a service for people who smoke, use alcohol problematically, and use drugs problematically. We provide medical treatment to help people with harm reduction attempts. We also provide outpatient group work using MI and cognitive behavior therapy. We do this at Department of Health clinics at 4 clinics. It's free for all the service users. And we've got a team of 3 behavior change counselors and a youth organizer and myself.
Any follow-up?
Okay.
Bianca, what did you want to say?
The rest of my team.
Yes, please.
Sorry, they thought that I had left out somebody in the team.
I was like, ooh.
It's so nice to see you again, Bianca and Angie. Hi.
Should I go ahead?
Yes, please do.
Okay, so we just wanted to share a few of our experiences. And perhaps, Angie, you can start talking about how you feel about MI in the groups that you facilitate.
Okay, so most service users who attend groups are already in a stage of action, and MI not as important. However, often we see parents who treat their drug using adolescents judgmental and even punitive. We need to work with parents to get them to be less confrontational with their children and more supportive. So we basically teach them the basics of MI, how to engage more, to be empathetic, to roll with resistance, to stay focused on behavior, and to affirm.
That sounds amazing, Angie. Herman, did you want to say something?
I mean, how do you feel the parents respond to this when you teach them this different form of approaching their teenagers?
Well, they, to them, it's totally new. And they are so focused on getting this child not to use drugs, not to be addictive to whatever they are. And they came to the group to, you know, to get the miracle touch. So they put the child in front of them. They just want this to be fixed and to be, you know, but when we teach them to be to get more engaged with this child, to be more empathetic and to see this as the child don't want to, and it is really a kind of sickness that this child is having or experiencing, and whether the child wants to quit or not, the child just can't. And so they need to roll with resistance more.
Yeah, I think often when the parent is so judgmental of their own kids and really pushing them to attend our services, the adolescents often resist and don't want to come. And as soon as we open up that relationship, they're very willing to come and see if there's something they can benefit from it. Perhaps, Bianca, you can talk about one of your service users in
my group. One specific service user that I see in groups and also individual sessions. Initially he came for his cocaine dependence, but I wanted to say, but he didn't admit that initially, and it was by using, the spirit of MI and key characteristics that you sort of got into the point of opening up on that later. But so he came for cocaine and then also alcohol, because that often triggered his cocaine use, but he wasn't really focused on stopping his smoking. And at Sahara, we often tell our service users that it's really much more beneficial to try to stop all substance use at the same time rather than trying to do it consecutively. But by using the principles of MI and really embodying the spirit, we allowed him to move at his own pace and to sort of set his own agenda and focus on his own, what he wanted to achieve from it. So really respecting his autonomy. And, he still comes to sessions, and he has stopped using cocaine. He's really drastically reduced his alcohol intake, and at the same time, he's really also limited his smoking to a significant degree. And I think that if we had sort of pushed our agenda of saying, but this is the way it should be done, and this is what you should be focusing on, that we would have lost him. And so really sort of rolling with that measure of resistance and also respecting his autonomy played a big role in him staying in treatment. And I think also the successes that he has achieved. And I also think on that point that MI really fits into our focus on harm alleviation rather than total abstinence, like as a lot of other organizations working in the same field often do. And I can also say with him that we did a little bit of an evaluation 2 weeks ago in terms of what his progress is, and he's but why are we doing this now? Why are we ending our sessions? Because I still really want to come. So that was also good to me, I think it speaks to just how we engage with our service users, and being collaborative and being participatory and showing empathy and really allowing them to just almost guide this process themselves, be the determiner of what I want to achieve, that helps us to sort of retain our service users.
Yeah, I think just to sketch the backgrounds better, all our support groups are open. We don't have inpatient, so it's really important to make service users feel welcome and keen to come back, because that's where we see our success, is if people stay in the program for long, and there where one really have to have a collaborative approach.
Yeah.
Perhaps Angie, do you want to talk a little bit more about your experiences now while you're doing the HIV training?
Well, I am presently doing a training in HIV counseling and have to shadow the HIV counselor. So I have observed how service users enter open-minded, but once the counselor displays a top-down approach to the service user, you know, like, I know better. The service user just shrinks into a shell. And after that, it is difficult to engage with the service user, never mind looking, you know, to change or to talk or any kind of behavior change. So I feel like I am in a kind of a compromised position right now, being the learner, but once I have completed the course, I will feel more confident to train her in MI. But I am already using MI to try and let the HIV counselor reflect on how counseling, on her own counseling style and how successful it is, and if there could be room for her to change.
I see that often when I train healthcare workers in MI, that they really start criticizing other healthcare workers and saying, sure, but our attitude is so bad and we're doing so bad. And I think a lot of healthcare workers are burnt out, have social problems themselves, are often depressed, and really depersonalize the person in front of them and just see them as a number, as a disease, and want to get moved by. And I've encouraged Angie to sit down with this HIV counselor and just listen to her and let her debrief.
Yeah.
Because I think as soon as you start getting in terms with yourself, it will be much easier having a person-centered approach and an MI approach to your service user. And yes, I mean, me as a doctor, I often work with staff that is quite confrontational with service users. And I try to engage them in it, but let them find their own way of connecting better with service users. Yes, I think we've got a few more things, but perhaps it would be good to get some discussion going with other panelists or listeners.
Well, I really think that the scope of your application of motivational interviewing surely is incredibly broad, both as practitioners and as trainers, and very, very impressive how you are applying it so effectively in so many different contexts. Goodman, would you like to add anything?
That the chat's really been focused on, you know, the style of communication, parenting style, and the impact, you know, on reducing traumatization during parenting as well, and how it impacts on development. So that's been interesting to follow in the chat. Otherwise, just wonderful to hear your stories about how you're engaging with these practitioners, and looking forward to hearing more. Thank you.
Okay.
Would you like to share a little bit more, Herman?
Yeah, I think we learning still how to apply MI in our group sessions.
Yeah.
Because it's something that, you know, we're kind of trying to teach ourselves and reflect ourselves on how do we really do this in the group, to engage with people, to look at ambivalence, and, you know, it's like a big organism, and the one, person who sits there says this is a con, and another one says this is a pro, and then weigh them up and let them, kind of go through the whole process as a group. And I find that very interesting and very rewarding.
Yeah.
But yes, I think we need to still get more confident in it. Yeah.
Yeah.
So it's a challenge for you, but it's something that you're embracing, and you're looking at how you can really apply it in a creative way.
Yeah.
And in a way that engages all the members of the group and that isn't isolating in any way. I can imagine that can be quite challenging.
Yeah.
Because often you have one or two members that participate more than others, and others that keep quiet. Yeah.
I mean, sometimes one can just do MI with one person, and the rest of the group is fascinated to watch this.
Yeah. Yes.
And actually also engage with it, even if they're silent. But you can see they're very focused on the process, and they're really interested in every step of this discussion.
Yeah.
And that's sometimes easy if you get into such a situation. And then at the end, just let everybody reflect on it and let everybody talk about it.
Yeah.
But it doesn't always happen naturally. It's, the change talk, how to get the whole group kind of to look at change talk, but, proper, not just saying I'm going to do this, I'm going to do that, but real, we often do scheduling where people look at the next week and what do we want to plan in the next week. And to really get interaction, that the service users themselves become counselors to the others, that it's not the facilitator doing that process, but the whole group learns how to take people through this process.
That's really fascinating, Herman. I'm wondering if any other of the panel members have any questions for Herman, Angie, and Bianca.
Yes, I got one.
Great. Hi, Steve.
Hi, Herman. Hi, all three of you. Lovely to see you. I saw you a year ago, I think.
Yeah.
Yeah, I remember very vividly. I'm just listening to this and wondering, how your learning needs can be met. And it's clear to me that you like chatting among yourselves and learning as you go along. But is there anything that people, trainers, whoever outside of you can help you with? Or are you saying, no, we're happy, we're learning, the groups are difficult, but we're learning and we're okay?
Angie?
Is it a crazy question?
No,
It's a really good question.
I really think I would benefit from engaging with other people who try using MI in groups to have a discussion about that and hear their experiences and, them feeding back to us. Possibly you could, I don't know. I was thinking if one films what we do and then get comments from somebody would possibly be an option, but then we obviously need to get buy-in from the whole group. Which shouldn't be difficult, but that would be two possibilities that I could think of.
Yeah, so it's not like you want to attend a course on it. If this network had to go well,
yes,
what would happen is it would connect you with others who could share your experiences and help everyone get better at what you're doing.
Yeah.
Okay.
There's a question in the chat. I haven't read it all, but I see there's a question about non-adherence to medication. And a lot of service users that get referred to us from, for instance, the ARV services, where people have interrupted ARVs because of substance use.
Yeah.
Yes.
And then they come to us with both issues.
Yeah.
We having to deal with the substance use and us talking about the HIV situation and the medication taking. And yes, I think we use MI very much in terms of getting people to think about their medication again and engaging them in a process of, and there's a lot of misinformation about not taking alcohol and ARVs at the same time. So often it's just dealing with some of the myths, but it's also a lot of just putting people on a new path in life, in terms of taking ownership of their life and taking decisions for themselves, in terms of their health, in terms of HIV, but also their substance use.
And again, it's not so much you need to go on a course, but you're almost talking about case-based discussion.
Yeah.
Yeah.
Yeah. Sorry, I'm talking about
About what?
the comment there.
Oh, you're
He's still
about...
talking about.
Somewhere there was a little bit of miscommunication.
Okay.
Both, I think you sort of addressed both issues. Yeah.
Yes, Bill.
Well, case-based discussion is where motivational interviewing began. And so I think that's a very rich area for learning. We've gotten very focused on courses, but the very kind of conversation that you're having with each other is where this whole process began.
Yeah, it's true.
I think what I'm trying to navigate in my mind is when you've got a group and you're engaging in trying to transfer the skills of MI. How do you navigate moving the group towards their individual industry and their individual motivations while focusing on the group discussion?
I think there's so many behaviors that the group, that applies to 90% of the group members. I mean, it's just these basic CBT lessons of staying away from triggers, getting engaged with other things. And obviously each person has got their own way of what their triggers are and how to deal with it. But that kind of focusing around that is often very similar, and people live in the same area. They know the same taverns, they know the same triggers, merchants and whatever. So often the discussion is not that individualistic at all. Obviously the childhood trauma that people went through is often very different. But the day-to-day struggles that we address now, people have lost their job because of drugs, people have lost their children because of drugs, people lost their parents and started using drugs because they lost their parents. It's very common themes that come in all the time.
But then from my side, I could perhaps add that that's why we also brought in the individual sessions, so that should people feel that some of their issues are not being addressed in the group, that there's a different space for them to then do that as well. So that one could almost say that, sort of like Herman said, the 90% of the commonalities could be addressed in the group, while at the same time still using principles of MI, etc. But if for whatever reason they might not feel comfortable discussing certain things within the group context, then we do provide a different space where we can focus more on the individual.
That's just fantastic. I think that I appreciate your contribution so much, and it's clear that there's an interest in further exploring all of these interventions, and especially the group work that you've spoken about. I wonder if, Bob, if you have any sort of thoughts around this, or specifically around the stuff that Zintle has spoken about, or any of our other panelists. I'm keen to hear your thoughts.
Are you talking to this Bob?
That Bob.
I wasn't sure if there was another Bob. Yeah, well, I'm quite interested in this last discussion on group processes. We've also set up a sort of a group process, people with diabetes, that's on motivational interviewing principles. And in fact, we constructed the whole around that sort of illicit sort of technique, which everybody, I suppose, learned about.
Yeah.
I mean, I think partly because there was quite a sort of a knowledge deficit as well in a lot of, which have never been explained. They've never understood the condition, you know. And so it's a way of sort of providing information while also evoking and eliciting in the group, you know, how I might deal with that information, how I might change. Also using group dynamics, you know, as talking, little group processes, even games actually, for people to share ideas and solutions with each other, kind of help each other to find things that have worked, because people are coming from obviously similar context, and actually some of them have worked out what works in a way that the people facilitating the session, you know, haven't really kind of got to yet. You know, so yeah, so a further discussion on group MI would be quite interesting, actually. Maybe a few webinar. Yeah.
What I enjoy very much is the discussions between generations, because we've sometimes got 15-year-olds and 80-year-olds in the same room.
Yes.
And we often see the parent, kind of the 35 years old, just being angry with their teenagers for not stopping drugs. And they're really kind of angry. And then we ask the other teenagers in the room, because they come without their children are at home. Then we ask the other teenagers in the room that, how do you feel? And then they say, no, I don't like this attitude of this mother. If this mother, I know why the child doesn't come to the clinic, because if she would treat me like she's talking now, I would also not have come. And then one of these grandfathers say, well, I have tried now for 2 years to stop smoking and I still couldn't stop smoking. So I understand these teenagers why they can't use their methamphetamine use, why they can't stop it. And it's really a very rich discussion how these teenagers respond to the grandfathers in the group and kind of cut away this adult adult generation.
The parents sort of generation.
Yeah. And often they've got an alcohol problem as well, which they just try to ignore.
Yeah, while focusing on the kids.
On the kids, yes.
My other reflection, I guess, is, I mean, Herman, your team, you're also kind of sitting in a primary care space, really, aren't you? Primary healthcare space, which is my space as well. And one of the things we've faced there is, of course, there's very few, there's very scarce resources, and there's lots and lots of people with and so having group approaches makes so much sense. You know, in that kind of context. And so it's another reason maybe why we should actually explore, especially in the healthcare context, group approaches, for various conditions or behaviors and so on,
I mean, as I said, we've got 3 counselors, and with this we can manage 100 people a month. Whereas if we would counsel everybody individually, we would never be able to reach that number of service users.
That's fantastic. Thank you so much, guys. It sounds to me like it's clear that we need some more discussion about this element. So we'll certainly come back to this. And I think part of what we'll do as we close today is we'll talk about what our ideas are for future webinars, and we certainly hope that you'll join us. I'm going to ask Steve and Bill to come back and join us, and just to talk about, there's 2 questions that I specifically want to sort of phrase to you that have been asked in the Q&A, but also just to get your thoughts about what's been discussed today. So I'm going to throw the questions in and allow you to navigate. So the first question, of course, is what is the difference between motivational interviewing and motivation enhancement therapy? And the other one is, so this question I probably could start to answer. Karine says, I find that there's a challenge to get a person to acknowledge there's a problem with lifestyle. Is it regarded as a sign of weakness by patients in South Africa? So that's a very interesting question. I'm not sure what is the sign of weakness. Is it the inability to acknowledge the problem with lifestyle, or is the lifestyle related problem the weakness? Maybe you can clarify that for us, Karin, and then we can come back to that question. Steve and Bill?
Well, the first question is fairly simple to answer. We decided that maybe it would be useful to add to the clinical style of motivational interviewing some personal feedback, some personal information about your own drinking level and so on. And so motivational enhancement therapy is simply the addition of assessment feedback to the style of motivational interviewing. And I think it's particularly useful with people who are more pre-contemplators or kind of less interested in changing to begin with. But that's the principal difference. We gave it a different name because it was in a clinical trial, but it's just MI plus some personal individual feedback. I didn't quite understand the question about weaknesses, but what occurs to me is we tend to focus on strengths. So what is it about the person that is resourceful, and what are the strengths involved here? And as soon as you begin looking at a patient or client through weakness eyes, you're stepping away from motivational interviewing.
I think Karin has provided additional context to help us understand. So she's
Good.
saying is the weakness is to acknowledge. So is it a sign of weakness to acknowledge that they have a challenge with alcohol or depression? Because usually they regard the problem to be disease like diabetes or HIV itself. Is it regarded as weak to be depressed or to have a substance use disorder? I'm going to actually, gosh, I hope you don't mind, I'm going to pull you in, Fergus. What are your thoughts about this? I know you went on the panel, but I'd like your thoughts about this. Karin wants to know whether being depressed or having a substance use disorder is considered a weakness, and whether this is a problem in South Africa.
Can you hear me?
We can hear you.
So I think Karin posed that question. It's a very useful question because often people out there and don't have a clear understanding of depression and substance use can feel or think that way about the disorders. Just to kind of state quite clearly that it's not a weakness. Psychiatric disorders like depression, anxiety, and substance use disorders have a biological underpinning. So we have to see them as disorders that have a brain rooting and need to be treated by healthcare professionals and not seen as a weakness or people operating from a deficit. So it's an important distinction to make.
Thank you so much, Fergus. Steve.
Goodman, you can get stuck also trying to get people to accept or admit a diagnosis, which may not be all that important in terms of change. In America, there's a lot of reluctance to admit that you have alcoholism or problems with drinking. But then if you ask the person what kinds of difficulties have emerged in their lives, they can give you a whole list of them. So in a way, it's just the idea of a name or a label or a diagnosis that can be the obstacle. Steve?
Sure. So much has been spoken about in this webinar, and looking at the comments, there's people who are fairly new to MI and wondering, well, what does it involve? And I noticed Bob raising this. I thought I'd make a couple of comments, Bill. Would that be okay?
Please.
Yeah. I noticed right pretty much from the off, Professor Bob Mash raised this very interesting question. Is this just about being person-centered, or is MI something more than that? And so our minds can get a little bit kind of split apart in that way, when in truth, MI is both person-centered, and I use the word person, not just patient or client, it's a person first. It's both person-centered and purposefully focused on change. that change, I think, as we've heard in these incredible stories today, can be in behavior, but it can also be in my attitude or in how I'm going to solve this problem. So no wonder when we hear this shower of stories today, we hear stories about being both person-centered and how fundamentally liberating that is for both sides, as well as this purposeful quality to MI. And I've also been very struck by, and I think Zintler articulated this because Lorraine prompted her, that the change started in her, and in Zintler's ability to, this is a challenge. I'm going to step back. I'm going to notice my own emotional state. And that helps me get the best out of them because I'm less confrontational. I'm less unconscious in how I react. And then my stress levels go down. So, yeah, so I just thought I'd clarify that, Bill. And I'm also wondering what this network can offer to people. And that's not something to discuss. But it's quite clear that there are offerings that this network in the future can provide. And I think the subject of groups is well worth pinpointing in one of our webinars. That'll be a really fascinating one. What does a group discussion informed by MI look and feel like? So, yep. And then there's vaccine hesitancy. I got a message on the thing saying, would I speak to that? But I'm worried about the time.
What I'm going to say before Bob comes on is that if you follow Steve on Twitter, he's posted some stuff about vaccine hesitancy and a few other things. So if you go and check that out, you might be led to some literature that might help your question until we can talk about it again in future. Bob, all yours.
Bill looked like he wanted to say something. I just saw him take a breath in.
No, go ahead. Go
ahead. Okay, well then, I think our time is pretty much up, isn't it, Goodman? And yeah, I think it's been for me, I mean, just the breadth of the ways in which people have utilized MI is staggering, actually, in this webinar. I think in future webinars, apart from maybe looking at group MI, maybe some other adaptations of MI that have been tried, we will also sort of introduce some information or stories on what research has been done in Africa and some of the evidence that's maybe been created in, hopefully in the sort of a user-friendly format. Yeah, I think that's really all I wanted to say, Goodman, and looking forward to the next one.
Yes, thank you so much, Bob. And we want to really make sure that we are responsive to all of your interests and that we give you stuff that you can operationalize and learn from. And if you're interested in research, to go and try out and give us some quantitative and qualitative stuff to play with and learn some more, access some trainings, increase your capacity to practice MI and to teach others MI, share MI. So we really are hoping that we can stimulate all of that with these conversations. So you will receive a link to this, to a recording of this session afterwards. There'll also be a contact, ways to reach us. So reach out to us and let us know what you'd like to hear about, what really struck you and what you're really interested in. I'm going to ask everybody to bring their cameras on so that we can be all on screen as we say goodbye to all of our friendly guests. So this is going to be the end of this webinar. We'll be doing these quite frequently through the year, so please do join us, and I hope it's been helpful for you and helpful for your growth. It's been lovely to engage with you. Steve, I don't know, what are we going to do today? So this is the end of the webinar. Usually we stick around for a couple of minutes. I don't know if so those of us who can stick around for a couple more minutes, we can do that, and then folks can ask us a few more questions. I'll certainly need to get going pretty soon as well. So we see all your thanks messages, and to the folks from National Department of Social Development, thank you for joining us. We look forward to continuing our training with you on Thursday. Otherwise, any of the panelists want to say something on our way out?
No, we're fine. Thank you very much for the opportunity, though. It was quite interesting. It's so sad I've missed the first one. But yeah, thank you very much. We all learn. I think this has like brought our minds into one thing, which is MI spirit, and I'm sure we will be circulating the information that we have, even especially with our colleagues. They really need this, and I'll be so glad maybe next time if we can come back to Lifeline and give us more of this training, since we got new social workers that are working with gender-based violence. But that is for you and the management to
Sort that out. We'll talk about it.
to sort that out. But then thank you very much. Thank you. It was quite interesting. Thanks.
Thank you, guys. Steve? We're good. Oh, there you are, Rich.
We haven't heard from Caleb Wang at all.
Caleb said hello and then he said goodbye.
So quiet, eh? Doesn't breathe a word. How have you found the webinar?
Fantastic. Really enjoyed it. Thank you.
Hey, good stuff. Good
Awesome.
stuff. We'll get you more active next time, eh?
So that's that. Thank you. Take care.
So what are you saying? Are we winding down now? Are we having informal chat? I've got 10 minutes and then I've got to fly.
Yes. So of the people that are left, if you want to ask Steve something or ask Bill something, we've also got Bob, we've got Caleb. So if you want to ask any of us anything, go ahead and we'll try to get to it. There is a question, what is MI, or how does MI differ from PSR? Is PSR psychosocial, what is PSR? Maybe someone else knows. Is it psychosocial rehab? Fergus, what do you think it is? Are you still there? Maybe Sandra, you could clarify. Fergus, your mic is on.
I'm not sure. I'm going to Google. I give it a Google and let you know if you haven't found it by then.
Cool. I suspect it's PSR. So if it's psychosocial rehab, Sandra, MI is simply a language that you can use in PSR. So it's part of the armamentum. In the same way that it's often combined with other psychotherapeutic approaches in brief interventions like CBT and problem-solving therapy. It equally can also be applied to many interventions. So if your question is, how does it differ? The answer is it doesn't need to. The wider question is, how does one go about setting up a facility that is MI-centered in a resource-limited setting? I'm in Botswana, and what I see often is healthcare workers not being able to incorporate it well for alcohol, drug rehabilitation, in care settings. Anybody can talk over me, you're more than welcome to, but my immediate response would be training, right? Access to training, access to mentorship and supervision. That's really the simplest way. I don't think you need to set up a building. You don't need a structure. What you need is access to the resources. Lauren, Bill, does that sound all right?
I've been saying that MI is a way of doing what else you do, whether that's diabetes education or HIV counseling or psychosocial rehab. It's a way of being with people while you're doing what you're doing.
100%, 100%. Thanks, Bill. There's a question from Radiant.
I just love that, Bill. I just love that.
I love that too. I think it's in our setting also so applicable, because whether in group settings, in your individual life, privately, it's a way of being.
Yeah, I running through all the stories today has been people's hearts. And so one way of answering that question is to say, it starts with the heart. And it starts with the personal values of the people around you, whatever the resource constraints. And I don't want to sound too much like a hippie here, but if you start with your heart and move forward and help people go through the kind of experiences that we've heard today about how they feel about an authoritarian approach and its limitations. And that's a journey, and it can unfold even in a resource limited environment, as we've heard from Herman and his colleagues.
It's fantastic. Radiance, I love the name, by the way, it's such a beautiful name. Has a question is, how do you hold a group MI with people at varying stages of change? And I think Herman and team kind of started to speak to this, is that you really, I think when you're dealing with a group, then you are a little bit more focused on what you're not trying to provide MI intervention individually. You're focusing on one specific area that then the group moves along together with. But I don't know if Bill and Steve have any specific thoughts about that. How do you hold a group MI with people at varying stages of change?
I would say help them learn from each other and acknowledge that they're in different places, and this is an opportunity to learn from each other, and give those that are less ready the opportunity to notice and to witness change in others. And don't be clever, and take concepts like stages of change out of your mind, because they're very rough approximations. Don't categorize and label people in this or that stage. Help people notice and learn.
Excellent.
I would say there's no alternative to doing groups with people at different stages of change. Even if you pre-selected everyone to be at exactly the same stage, they wouldn't be for long.
And I think if I might just add something, is the group education that Bob alluded to is a great project, which is great for diabetes, that we train group people, and that those would be healthcare providers at different stages within themselves in terms of their profession. And also, so I mean, it is a different kind of field, but it's almost like doing MI on the group. Yeah, it's so the great project is something that I think we should hear from, that we train people in MI groups.
Fantastic. I actually feel like Corinne's comment in the Q&A pane is a perfect segue to the end of the session. I feel like you summarize what we've been really talking about. Corinne says, MI at the level of our district is often more about changing attitudes of people and communities, right? So it's about changing attitudes and approaches. So it's not about fixing people. It's not about giving them the answers. It's changing the attitude towards solution seeking. So I think, Corinne, for me, you've really hit that nail on the head there. So from my side, I think that's it. And I look forward to sorting out the next one and to talking to everybody again. Thank you.
Thank you so much, Goodman.
Thank you, guys.
Thanks, everybody.
Thank you. So lovely to see everyone.
Indeed.
Bye.
Bye.